To record. All right, guys, good morning to all of you who are here and all of you listening on Panopto. What is November 3rd, 2016, a day that will live in infamy. No, not infamy. Probably, as Cub fans would like to say, happiest day ever. Yeah? And this is so I wish you guys well, and this is coming from a Chicago White Sox fan. I actually wear a watch with the 2005 World Series logo on it, and a lot of the Chicago orthopedic group is they're the team doctors for the White Sox. So we had a World Series win in 2005, and now we have one in 2016. So leaving the Cleveland Indians as the franchise with the biggest sports drought now. They are at 68 years. Any Clevelanders here? No? We usually have a strong Ohio contingent, but they at least have a championship, but they played well yesterday. All right, from happiest day ever for Cubs fans to something hopefully that should be very clinically relevant to you guys. The whole idea, and using my sort of baseball metaphors here, the idea behind this lecture is not to make you guys experts in electrocardiography, but the idea behind this lecture is at least to put you guys in the ballpark, so you at least kind of recognize what we talk about when we say electrocardiography. What's an ECG? What's an EKG? And at least you should leave here after the 45, 50 minutes feeling that I kind of sort of belong in the ballpark. I may not be the expert at it, but I kind of get my way around certain things. First things first, some objectives. We may get through all of this, we may not. So long as we get through some of the key top ones over there, and you can identify some of the key issues. So the utility of an electrocardiogram, where do we place the leads? What are the waves on an ECG? Defining normal intervals of an ECG. How do you calculate a rate from the ECG? Identifying certain pathologies on the electrocardiogram when it's not normal, and identifying and sort of localizing coronary ischemia and infarction. So on a practical standpoint, electrocardiography is important to us from a whole host of different values. So for you guys sitting out there in your M1 year now, you've probably heard the term electrocardiogram, right? ECG or EKG, which is sort of the German way of saying it. But most of you had heard about this. Anyone, why would we even do one of those? What's the point in doing an EKG, or from your vantage point? You can yell something out. Even though you're in your Cubs stupor, yell something out. Why would you do an ECG? Like heart things, like things of the heart. Now you're a medical student, so we want you to be a little bit more sophisticated than just to check heart things. What heart things? What does the heart do for you? So it's a pumping device, and what else does the heart do for you? Is the heart just a pumping device? What else does the heart do for you? When you listen to someone, what are you listening to? Their rate and their rhythm, right? So it's an electrical organ too, right? Remember the depolarization, the mechanical event follows the depolarization, right? So we're essentially talking about a device, a piece of information that you get about the plumbing of the heart. So what's plumbing have to do? The walls of the heart, the vessels of the heart, these sorts of things. So indirectly, an electrocardiogram gives you information about the rhythm of the heart, the rate of the heart. Remember, we have an SA node, we have an AV node, we have chambers in the heart, we have valves in the heart. This sounds like a high school physiology lecture, but you guys know that, right? I'm not talking, you guys are med students, so you should know this already by now. So that's what you're actually looking at. It's a surrogate marker of both the electrical activity of the heart and the mechanical activity of the heart. I usually like to get engaged with you guys, so if you're used to very boring, monotonous lectures, this will not be one of those. And I will get you guys to be involved. So one of the advantages of actually showing up to lecture this early in the morning is we will participate, some banter back and forth, and I will be picking on you guys to answer a few questions. Is that okay? Can I hear yes, a loud yes?
Yes.
That wasn't a loud yes. Come on, you can say a loud yes.
Yes.
There we go. Okay, good. So, as I told you, the rate of your heart. So every time a patient walks into your office, the nurse or the medical assistant calculates, oh, their pulse is this. That's what we refer to when we say rate. Rhythm. Where is the origin of the impulse coming from? Is the rhythm sinus or not? That means, is the SA node the driver of the rhythm of your heart? Is it the AV node, or is it some other place? Axis. We won't focus on axis here. That's something that we'll kind of build on in probably your third year. Hypertrophy. How thick are the muscles of the heart? And injury, myocardial ischemia or infarction. So, one thing I want you guys to remember right now, what an electrocardiogram is. What are the three big words about real estate? Someone. Ah, yes. It's all about location. Repeat that again. Location, location, location. That's all an ECG is. So for example, you had a nice car over here, take an Audi R8, and you're looking at it, and you're at the auto show, you get a view from the front. You're like, oh, that's the front view. Then you have a side view, you have a top view, and you have a bottom view. You have an inferior view, you have a superior view, you have a back view. All the electrocardiogram is that I took 12 pictures, electrical pictures, and my heart sitting like this in my chest wall cavity, and I decided to put 12 points on that heart to give me information, electrical information, about those 12 locations of the heart. That's all an ECG is. So you're essentially taking information from those 12 vantage points, putting it on a piece of paper, and you're saying, aha. And depending on where the lead is, it guides you to the geographical location of the area of the heart that you're looking at. So it was decided, by convention, that you would have two sort of frames. You'd sort of have a horizontal plane like this, and you sort of have a vertical or sort of a coronal plane. So there are some leads we refer to as limb leads, 6 of those, and there are some leads that we refer to as ventricular leads. And take a wild guess, the ventricular leads cover the... There we go. That's EKG. We're done. You can go home now. No, I'm kidding. It's just the beginning of it. So you basically take a lead. So whenever you guys are in the student continuity experience or in your RICSIP environment and you have your EKG machine, you take one and you say, okay, this is lead 1. It goes from my right arm to my left arm here, shoulder area. Then you have lead 2 that goes from this side to the leg, and then one that goes this way and there. And it's like, oh, those are only 3 limb leads. And you said there were 6. Well, let's leave them at 3. Then you have your heart sitting like this, and you have leads that go precordially this way. So they're leads that are going this way and right across the heart this way. And that's sort of how your heart sits like this in your chest wall cage. So we call those the ventricular leads. They go V1 through V6. V1, fourth intercostal space, right sternal border. So, intercostal space, right sternal border right up here. You sort of V1, V2, and then you go the mid-clavicular line and axillary line. Right here is V6, so that would be the lateral side. So V6, you're probably talking about the lateral side of your left ventricle. And then you have V4, you're like sort of V3, that's your anterior side. V1 and V2, sort of that septal area there, and maybe the right ventricle. So this is V1 through V6. So these are where we place those 6 leads. And then we have the limb leads that we talked about going this way, 1, 2, and 3. We decided that we needed a little bit more information from the limb leads. So what smart people did is they rerouted a few of the limb leads, and they said, oh, we'll take one limb lead, we'll attach another electrode here, and we want information about the right side of the heart. So we call that AVR. We want information about the left side of the heart. We call that AVL. And we want information about the floor of the heart, and we call that AVF, floor, inferior. So 3 limb leads, 3 augmented leads that are part of that up and down sort of process. And then you have ventricular leads, which are sort of your precordial leads. And this is sort of where you see the location. You have V1 through V6, V1, V2, V3, V4, 5, 6. So you can clearly see, depending on how your heart is placed, left ventricular information, 4, 5, 6, maybe a little bit of 3 and 2 in there, and V1. And voila, if I have a problem, I'm looking at a lead that's a V6 lead, and there seems to be an aberration there. The way you guys are supposed to think is, hey, there's a problem with V6. Wait a minute, that's that left ventricle lateral side. Hey, wait a minute, what artery supplies that left ventricle lateral side? Aha, so I'm in the emergency room, I can call my cardiologist and say, hey, when you go to the cath lab, you're going to intervene with this particular artery. You're going to put a stent in that particular artery. Not too much more difficult than that. And then this is sort of the limb leads, where we're talking, this is sort of the vertical plane, this plane. So the precordial plane goes like this. The vertical plane is this way. So that's 1, 2, 1 that way, 2 this way, 3 this way, and then augmented lead, AVR, gives me information about the right side of the heart, AVL, left side of the heart, AVF, AVF, floor of the heart, inferior portion. So when we take the electrical information from all of those 12 leads is what we get a normal 12-lead EKG. And each information, so this is the information from lead 1's vantage point. So it's a picture being taken from lead 1. You know, it's sort of like you taking a picture and you're saying, okay, these are 12 different views of this particular thing. And, you know, if I was looking at this just from the diagonal side, this is what I would see. But hey, if I looked at it from the other side, I'd get a different view. Same thing with the car. You know, it's like depending on which areas you're seeing. That's all an EKG is. It's the identification for you of a geographical location on the heart. So the machine then generates all of these 12 vantage points, all of these 12 viewpoints, and tells you, now make your decision. What do you think is going on? So what is the vantage point? What information are we getting? We're getting electrical information, which therefore then we deduce a whole host of other things about the heart, mechanical information, electrical information. You see these little thingies like up, down, and these little lines. Anyone know what these lines are? What the hell is this? What is this tracing? It's like a zzz, ding, 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 ding. What is that? What are those? What are those? What are these lines? I got 12 different pieces of information, but I'm getting these lines, and something goes up and down. Huh?
You can't see your mouse.
Oh, sorry. Well, they can't see the mouse. Oh.
You gotta go all the way to the right.
All the way to the right here? Ah, this is one of those other screens, so I should talk to you from here.
Ugly problem with the computer.
Oh, I did not know that. I stand corrected. All right, so now I'm extremely right, which I don't like to be, so I have to go back this way. Moderation is probably not a bad idea for Tuesday. Remember, that's voting day. That's just a side view. Okay, all right. What are these things? I got 12 pieces of information about the heart, and I got those D. They're just these dinky things. What are those? What's the information about the heart that we're getting? Pardon me? Aha, so what you're telling me is you're going to give these guys some names here. And so you're telling me that this little up bumpy thing is something, and then this little thing here is something, and this is something, right? What is this thing? P wave. What is this? QRS. And what is this? As a class, what's the P wave? Boom! What is this? Ventricular depolarization. And what is this? Repolarization. So we got that, okay? So you're getting PQRST information from 12 different vantage points. Awesome. There's another thing with this electrocardiogram. You see these little boxes? So from here on out, this is going to be referred to as the large box, and then you have this little box here. And we will refer to that from here on out as the itsy bitsy box, okay? So we have an itsy bitsy box, and it becomes very important shortly, and we have a large box. Itsy bitsy box, large box. I used to like this movie, Philadelphia, with Denzel Washington, and every time he'd go in front of the jury, he would ask the witnesses to explain stuff to him like he was a 4-year-old or a 5-year-old. And I think in medicine that works too. I think it's better to understand tough concepts simply, and then you can kind of build on them. So, because your patients ask you to do that. Like when you show up to the room, you say, oh, you got this, you got a PQRST depolarization problem, and that's what you have, ma'am. And she'll be like, what? And you'll be like, oh, you have this. This is what's going on. So you should be able to talk to your patients in a common sense sort of a way. So we got P, we got QRS, and we got T. Everybody familiar with the itsy bitsy box, big box? What's the x-axis on an electrocardiogram? What's the x-axis? What's the y-axis? Voltage. X-axis is time, y-axis is voltage. One large box from here to here is 0.2 seconds. One itsy bitsy box from here to here, which is because 5 itsy bitsy boxes make one big box, is 0.04 seconds. Everybody clear with that? So therefore, if you have one ventricular depolarization like this, which is basically the rate of your heart, and I have this, every one large big box, what's the rate of my patient? So you have this, every big box. So that means you have one beat for every 0.2 seconds. In 60 seconds, how many beats would you have? 0.2 equals 1. 60 equals 60 divided by 0.2. 60 divided by 0.2 is the same thing as 600 divided by 2, which is the same thing as 300. So a simple way of calculating the rate of a patient is how many big boxes between these depolarizations. One big box, your rate is 300. Two big boxes, 300 divided by 2, 150. And in this particular case, how many big boxes, just roughly, between two depolarizations? About 3, right? And slightly more than 3, so it's 300 divided by 3. Your rate is about 100. See? That's where that big box thing really helps you, because one big box, 0.2 seconds. And we'll keep going further. So complexes. You already answered this. PR interval. So now, this is the P. From the beginning of the QRS, we call that the PR interval. This is the PR segment, not the interval. This is the QRS, and at the end of the S, to the beginning of T is what we refer to as ST segment. An elevation of the ST segment is what we refer to as an ST elevation MI, an acute coronary syndrome. So that's how you can kind of diagnose that. And this itsy bitsy box, 0.04 seconds. This big box, 0.2 seconds. Atrial depolarization, PR interval should be isoelectric, and the normal is about 3 to 5 itsy bitsy boxes. Prolongation usually implies there's a delayed conduction through the AV node, and these are what we refer to as your atrioventricular blocks. QRS complex represents ventricular depolarization. The first upward deflection is known as the R wave, so this one is the R. The first downward deflection is the Q. And then first downward deflection after an upward deflection is known as the S. And usually it should be anywhere from 1.5 to 3 itsy bitsy boxes. Anything more than that, it's prolonged. And yes, this is voltage. So this aspect of it is voltage. And the higher this is, suggests that more voltage is being conducted through the cardiac tissue. So the thicker your cardiac muscle is, the bigger the deflection that it is that you will produce. So that would then help you with things like left ventricular hypertrophy. And that's your ST segment again there that we discussed. T wave, upright in certain leads. Again, depends on your vantage point. Which way is the impulse moving? Remember, with Einthoven's triangle, you talk about the net electrical activity of the heart going a certain direction. And that's why your point of maximal impulse on physical diagnosis, when you're feeling your pulse, there's a certain direction where your impulse goes. So if I put the lead opposite from it, I'll have a downward deflection. General principle of physics. Current moving towards you, upward deflection. Current moving against you, downward deflection. So in some leads, it's normal to have a downward deflection for certain things. And in some leads, you should be having an upward deflection because the current is moving towards your direction. That's all an electrocardiogram. So remember, geography, location, is the current away from me or is the current moving towards me? Again, positive complex, negative complex. We've gone through the boxes. So this is what I wanted you guys to kind of commit to memory. So if I have an impulse, every one large big box, that means my rate is 300. If it's every 2 boxes, large boxes, 150. Every 3 boxes, 100. Every 4 boxes, 75. Everybody clear with that? Everybody clear with that? Yes? Yes? Okay. All right. Good. Again, back to a normal EKG. I keep showing you that. All right. The first question, the first thing we're going to do together is going to calculate rates. Okay? So whenever we calculate rate, you must say, okay, so what the hell is normal rate? And what do you guys know as normal rate? Usually it's like between 60 and 100. Though, you know, some people will, at 100 are like, that's maybe high normal, kind of depends. You know, if you're a marathon runner, that may not be normal for you. So you decide if the rate is fast, tachycardia, or you decide if it's slow, bradycardia, or normal. Brady under 60, tachy over 100. And then you have to also decide which pacemaker. So if the pacemaker for your heart is your SA node, and that's why your pulse rate is between 60 and 100. And what if you knock that off? What becomes your de facto pacemaker for your heart? The AV node, and that's intrinsic rates about 45 to 60. You knock that off, your ventricular tissue starts taking over intrinsically. That's about 35 to 45. Hopefully not a good thing, but and all may be faster or slower depending on pathology. So this is normal sinus rhythm, okay? You have a P wave. So what we've done is we've taken one of these leads, one of these 12 vantage points, and a lot of the nursing staff on the floors, on the general medical floors, they will have these printouts of these rhythm strips, and they'll come to you and they're like, hey, what do you think of this rhythm strip? You know, what's going on over here, doc? And you pull it back and you're like, oh, it's not the 12 lead EKG, but we decided to pick V1 or lead 2 or whichever, and you're kind of looking at it, and sometimes it makes for a better vantage point to say, okay, what's going on at an individual lead level? And at an individual lead level here, P, QRST, P, QRST, P, QRST, P, QRST. Okay? Everybody clear with that? P's are occurring regularly with identical morphologies. There's a PR interval, constants and within normal limits, and a QRS following each P wave. That's normal sinus rhythm. So if you don't see that and there's some aberration in that, then there's a problem. Okay? Okay, we're going to practice here. All right, you guys have 2 minutes, pair up, and you're going to tell me what the rate is on this rhythm strip. I'm not pairing up with anyone. No friends. Move on, come on. Come on. You guys don't bite, do you? Can you join you guys? Is that okay? All right, we got those 2 up there. We got 2 up here. Come on. Join. It's good to be together. Use the big box rule. You guys got 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 1. What's the rate? 75. What's the rate? What's the rate? You two over here, you didn't talk to each other, you just decided to go along. What's the rate? 75. What's the rate back there? It's 82. Sorry, it is 75. Yes! And what would you call this? Normal, tachycardia, or bradycardia? Okay, that's normal. Very good, boys. All right, do this. You got 20 seconds. And remember, we've been talking about the big boxes, so you know how many big boxes here in between your two impulses, your two rhythms, because remember ventricular rate, polarization, that's your rate, that's the rate of the heart. When you're checking your pulse, that's what you're checking. Everybody together on 3. 1, 2, 3.
57.
57? How did you get 50? Is that divided by 300 somehow? Give me the 300. How many big boxes do you guys get? 6. So some of you say 6, some of you say 7. So what's 300 by 6? 50. What's 300 by 7? You guys get 7 boxes? Really? So it's 1, 2, 3, 4, 5, 6. So slightly under 6, slightly over 6, but not 7 boxes, right? So close. If you were to approximate this by the 300 rule, by the boxes rule, you got 50? Are we okay with 50? Okay. What do you call this? So you guys are now rate experts, baby. Sinus bradycardia. See, all of you. So what if you're M1s? You can go on the floor now and you can say, I can pick out sinus bradycardia, baby. All right, do this. You have 10 seconds. On 3. 1, 2, 3.
175.
Is that divided by 3? Where are you getting these numbers, 175 and stuff? How many big boxes between each one? 2.5, right? So 2 big boxes would give you a rate of 150. 3 big boxes would give you a rate of 100. So it should be between 100 and 150. Who got 175? What's going on, man? Is everybody clear with this? What do you call this? What do we call this? Come on. While we're young here. What? Tachycardia. Good. So you guys are experts in Brady. You've identified a normal rhythm. You've identified a bradycardia. And you've identified a tachycardia. Give yourselves a hand. Come on. Is that what you guys call giving yourselves a hand? Come on. There we go. All right. Now we get a little bit interesting. Okay. Very important for you guys to recognize that there's a P wave before every QRS, and then you have a T. They're normal intervals, so that's what we call normal sinus rhythm. So whenever you're listening to somebody, you're always putting your stethoscope in those 4 cardiac windows, and you're saying they had a regular rate and they had a regular rhythm. You know, consistent. The PR interval here, if you notice, I told you that the beginning of the P to the beginning of the R should be only 3 itsy-bitsy boxes to 5 itsy-bitsy boxes. Here we have 1, 2, 3, 4, 5, 6 to 7. So 0.04 times 6 is 0.24, and 0.04 times 7 is 0.28. So it's in between there. So the PR interval here is prolonged at 0.26. However, notice this. There's always a QRS after a P and a T, P, QRS, T. The only problem with this rhythm strip is what? That the PR interval is prolonged, but it's prolonged at the same time in each cycle, with each impulse. Everybody clear with that? What's the rate in this patient? Can you give me a rate in this patient? I'll give you 10 seconds. Roughly how many big boxes between those two impulses? 4. So what's your rate? 75. Yeah, we got, all right, good. What do we call this, guys? You still have your ventricles, your AV node still beats, captures the ventricular depolarization, but there's a slight delay. So this is referred to as one of your blocks. This is one of your atrioventricular blocks. This is called first degree atrioventricular block. All it means is that your PR interval is prolonged at the same rate throughout, but you have a normal QRS&T, not pathological. We observe patients like this. So this is first degree AV block, or also referred to in older textbooks as first degree heart block. Is everybody clear with this concept? All first degree AV block means is PR prolongation, fixed PR prolongation, with each time followed up by a QRS and a T. Notice what happens here. P, QRS-T, P, QRS-T, P, QRS-T, P, boom, you drop a QRS, and then back to P, QRS-T. Second degree blocks mean that every once in a while you don't conduct a P wave. And there's two types. The type 1, if you notice, the PR interval keeps prolonging and prolonging and prolonging. It's not fixed like first degree AV block. So it's like maybe 5 boxes here, 6 here, 7. So it keeps prolonging to the point that you drop a QRS. That's referred to as second degree block type 1, or Mobitz type 1. Another old-fashioned name for this is Wenckebach. But just remember, this is a second degree block type 1. Contrast that with type 2, which is normal PR interval, PQRST, 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 P, no QRST. So all a second degree block is that you're dropping a QRS every now and then. Type 1, you keep prolonging the PR, and then you drop a QRS. In type 2 second degree block, the PR interval is fixed, it's normal, and you're just dropping a QRS. These are more ominous than the first degree block. You can imagine that if you drop a QRS, you don't have ventricular depolarization, you don't have ventricular systole, you don't have that, cardiac output gets compromised, and a whole host of slew of things could happen, okay? And then last but not least is when your atria decides to beat on its own and your ventricles decide to beat on its own. Irrespective, there's no connection between them, and that's what we refer to as third degree AV block. That's complete heart block. So P waves, you can chart these out and they'll be coming at their own intrinsic rate, and you have a QRS complex that's independent of whether the P came before it, sometimes the P is after it. It's beating at its own rate. If you count the number of boxes, 1, 2, 3, 4, 5, 6, almost 7 boxes in between the ventricular impulses. The ventricular rate here is almost like 300 divided by 7. And you can start speculating like it's in the, so that means the ventricular cells are beating on their own, which is not very good. And the atrial rate here also is pretty slowed down. So this is a dissociation. You require a pacemaker for this, just like you would for a second degree type 2 block. So those were the blocks. Traditionally, whenever we talk about the rate of the heart, most textbooks will then divide it up into normal rate, bradycardia, and tachycardia. And then under bradycardia, just as a classification scheme, the blocks are then taught that way. So we traditionally teach the blocks that way because you do see some corollary with slowdown rates there. So we've talked about normal rate, bradycardia, tachycardia. Next step was blocks. First degree, second degree, there are 2 types. You're dropping QRSs. One, you drop it because your PR keeps prolonging. And in the other one, the PR stays the same. And then third degree block, P's and QRS complexes are beating based on their own intrinsic rates. They have no association with each other. Is that concept clear? So you guys are now rate experts. You're also rhythm experts. That's where a lot of these clocks come in. Rhythm. Is it sinus? Is it first degree, second degree, or third degree? Everybody okay so far? We're in the game. We're in the ballpark. You don't have to be the experts in the ballpark, but you're at least in the ballpark, right? You're getting a hot dog or something, you know, you're getting, you know, something. Yeah? You feel like you're doing okay? Peanuts, hot dog, something? Good? I want a resounding yes so that I can continue. Good. All right. The next big thing I wanted to talk to you guys about was when I look at the heart personally, I'm looking at an electrical organ and a mechanical device. So that whenever there's a problem with the heart, there's the electrical side. So make sure you guys are intricately involved with what the SA node does and what the AV node does and what the rate is and what the rhythm is and what the blocks are. So that's the electrical side of things. But then I spent a lot of time in the beginning of this talk really emphasizing location, location, location. That helps with the plumbing side of the heart. That's where the ischemia infarction, the supply-demand stuff comes in. So if I have already told you where the leads are, and I've told you that this is right-sided lead, and this is a left-sided lead, and this is a ventricular lead, what kind of information can we deduce from that? So it's usually about ischemia or infarction. Lack of blood supply, or a complete block. So from an arteries level, if you're just looking at it from the standpoint of a coronary vessel or coronary artery, it could be narrowed. We call that narrowing of due to a plaque. And the plaque could be from a variety of reasons, cholesterol, macrophages, things like that. And it could be narrowed, and I'd be fine today, but I'd say, hey, doc, every time on Saturday that I try to mow the lawn, after about half an hour, I'm getting chest pain. So demand goes up, but my supply has been restricted because of a plaque narrowing. That we refer to as ischemia. Or, in other lingo, angina. That's stable angina. When you rupture that plaque, for a variety of reasons, when you rupture that plaque and you start occluding your vessel and platelets come in and all sorts of other junk is coming in, and you start occluding your coronary vessel, your pain's intensity and frequency goes up. We refer to that as unstable angina, or one of the acute coronary syndromes. And when it completely occludes the vessel, that's what, my friends, we call a myocardial infarction. So acute coronary syndrome is after plaque rupture. It could be unstable angina or an MI. And nowadays we quantify MIs as ST elevation MIs or non-ST elevation MIs. So now you can see, going back to your PQ or RST segment, if that's elevated, you have an MI. If it's depressed, it's ischemia. Maybe it's not fully occluded, partially occluded. So everybody clear now with that definition of what an acute coronary syndrome is and what angina is? Ischemia, infarction, ischemia, infarction, supply, demand. So classic ischemia pattern. Do I press this? Oh yeah. It's showing here but not there. Do I? The slide deck is not moving on here. It's moving here, but not there. So is everybody clear with that concept of ischemia and infarction? Must be me. Did I mess something up?
Just gotta click that one.
Okay. Thank you. Thank you. So do you see this? ST segment depression or a T wave inversion is ischemia. That means you have not infarcted yet. Okay? The vessel is not completely occluded. It's partially occluded. Maybe there's a thrombosis going on. That's ischemia, angina, that sort of thing. ST elevation, this. From the baseline, the isoelectric line, that's ST elevation. Or this, like the tombstoning pattern that people talk about. Okay? So for your purposes as an M1, you hear the term ST elevation, infarction. You hear the term ST depression, ischemia. Got it? Got it? Okay. So transmural infarction, that means throughout Q wave formation. This is that Q wave we're talking about. ST segment elevation, sometimes depression. T wave inversions are also seen. So this is sort of like the evolution of an infarct. And the reason they form is depending on whether you have a transmural or a subendocardial infarct. All right, big deal here. Big deal, big deal, big deal, big deal, big deal. Is this a big deal? Yes, it is a big freaking deal. You'll see this on your test or whatever. Right, Tom? I'm going to write some questions on this. So this is a big deal. Big deal, big deal, big deal. And when I say test, I mean like that final assessment thing you do, not those very easy formative assessments. Yeah. I'm talking about the real big, the big Hefe Anjo ones. One of the things that I've been very happy about, and thank you guys, and all through Panopto, I'd like to thank all the M1s for being very receptive to our M1 clinical cases. We got your feet wet, and now we're going to incorporate more clinical scenarios on your tests too, based on those sessions that we have. So this should be very good for us, and I'm going to probably lead off with this case that we'll do next on the 14th and 16th that has a lot of relevance to what I'm talking about today. So this is stuff, guys, that's bread and butter. This is stuff that any clinician, no matter what field you go into, needs to know. So you need to know this. So, and hopefully it's being presented in a way that it's not too difficult for you guys to understand. When I went through the leads, I said there were 6 limb leads that were going up and down, and I said there were 6 limb leads, 6 precordial leads. V1 to V6, my heart sitting this way, ventricular information. Lead 1 is probably giving me lead 1, maybe right side, maybe the right atrial, right ventricle as it's going. Lead 2 going down this way. Maybe you would say, I'd get some inferior information. So I simplified it for you. When you look at lead 1, sorry, get this mouse here. Lead 1, AVL, left side of the heart, F, floor of the heart, inferior portion, V1, V2, septal, V2, V4 anterior, V5, V6 lateral. This is how we localize. This is the location of the electrocardiogram. Now, let me flip it to you guys. What arteries supply those areas? So coronary vessels. Step back. What are your coronary vessels? Have you done them yet? It's not hard, right? The coronary anatomy is like really simple. I mean, come on. I was so happy, like with coronary vessels. I'm like, there's not a lot of arteries. Awesome. And so you have the left main, right? And then that breaks down into what? LAD and circumflex, right? And then you break down into, and then there's the right. And what's this business about being dominant? What does that mean? Why are you right dominant versus left? Whichever is supplying the posterior descending coronary artery, right? And 80% of the time that is right coronary. I thought you guys told me you've done the coronary anatomy. I'm like 20 years removed from this crap, so you guys better know more than I do. Really? So does that sound somewhere similar, like there's a left? The circumflex supplies which one of these areas? So which artery is lateral? So you go in, you're looking at the EKG, you're in the ER, you're like, hey doc, it's ST elevations in these lateral leads. Which artery should I be stenting? Circumflex. Awesome. Inferior. Which artery should you be stenting? Which one? Right. Coronary artery. Awesome. And again, there could be nuances along the way, but you know, as we're keeping it black and white, at an M1 level, it's right coronary. Septal. Which artery are you talking about? LAD, the widowmaker. That's the one you're talking about, right there. Anterior? LAD too, probably, right? And then you have your obtuse marginals and things like that. So from a basic fundamental standpoint, see how the electrocardiogram helps you? I can pick up the phone and say, hey, we think we have an anterior wall MI. We think we have an inferior wall MI. We think we have a lateral and an anterior wall MI. Right now, at this level, at this time, you guys could do that. You guys could go down to the ED with me or go on the floors with me and say, look at this electrocardiogram, tell me where the deficit is, where's the supply problem? And then you call cardiology and say, we think it's this vessel. They go in, they're like, you were right. We had to stent that vessel, and we put the stent in there, and we did this or we did that. So that's the reflection. So ST elevation MI, acute thrombosis, gives you a whole idea of location. And again, these are the precordial leads that we talked about. These are the limb leads that we talked about. And last but not least, I wanted to leave you guys with this. So you are all, after today, you should all be rate experts. You should be able to tell me something about the rhythm. And when I mean rhythm, is there a P before every QRS? Is this a first-degree block or not? Is it a second-degree block or not? Is it a third-degree block or not? Then you should be able to move further from that and tell me, hey, location-wise, do I have injury, ischemia or infarction? And can you tell me which vessel is involved based on the electrocardiogram? This one was a little bit about just showing you guys a little bit of an ST elevation here, ST elevation in V2 and in V3, some of very older things that we have. Circumflex, lateral, right coronary inferior. And for this, so the last 5 minutes we have, this is a guy who comes in with 65-year-old man with substernal chest pressure. Follow my rules and tell me what's going on in here. So rate, rule number 1, rate. What's the rate here? So what's the rate here, guys? You have 10 seconds. What you could do is pick any lead. Pick any lead. And you could say pick, 2 or, down here you have V5, lead 2. How many big boxes in between the impulses? 3. So roughly 300 divided by 3? 100. Do you think it's slightly less than 100 or more than 100? Less. So slightly less than 100 is the rate here. So it's not tachycardia. Good. Rhythm, is there a P before every QRS? I see my good do you see a good all-American P wave here before? You see a good, nice little big all-American P wave? That's Tom Brady right there, QRS here, boom. We've got P. You can't see it? So there are these little, sorry, I have to bring my mouse back here. So P wave here, P wave here, P wave here. So that's rate, rhythm. Do you see hypertrophy would be if you're going all the way up? That's that y-axis. Do you think that there's a lot of hypertrophy here? Usually if it's more than 5 big boxes or 6 big boxes here, like 1, 2, 3, 4, 5. So a lot of these impulses are not tearing right through the page. So it doesn't mean like we have a thickened hypertrophy. And then injury and infarction. Do we see anything here that is telling you guys that there may be ST segment issues? Where? V2, right, there we go. V3, we have some issues. Which artery is the problem? So I can ask you this on your test. Throw this EKG up. Tom, that would be a good question. I'd pull up this EKG. It would have an attachment on ExamSoft. I'd say, boom, boom, boom. You're the doctor in the ED. You call him up cardiology. Which artery do you intervene? And you would tell me? You'd tell me with a lot more vigor than that. You'd say, LID, damn it, I spit on this question. Ask me 2 more hard ones. That's what you would tell me, right? You'd say, we need more Shah questions on this final because they're so easy, right? Is that what you're going to tell me? Yes, that's what I like to hear. I spit on this. Give me another one. Give me step 1 right now. That's it. You are rate experts. Brady, tachy, normal. The next thing you look at in any EKG is PQRS, and you're looking at that PR interval, and you're telling me if it is a first-degree block, or it's just prolonged. You don't drop a QRS. If you're dropping QRSs, you're in a second-degree block. And the only question there you have to answer is, was it prolonged? PRs kept getting longer and then I dropped the QRS? Or was it just a fixed PR interval? AV conduction was okay, but I'm just dropping a QRS for some reason. And that's pathologic because your AV node's not working well. The third degree is no association between what the atria is doing and what the ventricle is doing. You have an independent atrial rate, independent ventricular rate. And remember, when you have an independent ventricular rate, you're beating at 35 to 40. That's not compatible with life. So those are the key messages from the rate rhythm side. And then the last message I wanted to leave you guys with was the rotation message. So all you gotta know is you have 6 precordial leads and 6 limb leads. They're giving you just 6 different vantage points of the ventricular side of the heart and 6 different vantage points about limb leads, like going this way. So you're like maybe the inferior side, right side, left side, the floor side. And so that's all an EKG is. It gives us great information. So going back to that question earlier in the beginning is, so why would we even do one? Right? It's a good tool to have. It's not that expensive. It's not that invasive. You just put a lead in and say, I'm getting information about somebody's electrical activity and by inference, their mechanical activity, the plumbing device. Are they having them on? Are they having it? So the next piece that we'll build on this, and hopefully as I see you guys next year, is we'll now add to this piece, and we'll say, hey, what if there's an arrhythmia? And under tachycardia, we have a slew of arrhythmias. You guys hear about them on, you have all these places, sports facilities, airports that have these AEDs, automatic, external defibrillators, and you just put them on someone and say, oh, they're in DTAC. They're in ventricular fibrillation. So that's under that tachycardia. And that all happens because some rhythm happened and it's going faster than it's supposed to go. This is what Dr. Shannon will talk to you again about the reentry circuit. And whenever you're depolarizing, you can have a reentry circuit, you can have trigger depolarizations, you can have active depolarization depending on your cardiac action potential. So we'll build on this for next year. There's a lot of drugs we use that block the AV node, that block those channels that you'll be hearing about. But for today, the purpose was to just move you into the ballpark, and it's okay. So that when you hear the word electrocardiogram, you don't get a seizure. You kind of get okay, ballpark. I kind of know a little bit about this. It's not a big deal. It's not a big deal. And then next year we'll build on this, and hopefully when you get to the floors with us, we can then get to the finer details of, hey, all that EP stuff, like, hey, now we can ablate some of these vessels. Pure atrial fibrillation. We can do a lot of these different things. Get the catheterization angle. Any questions? Is this clear? Yes.
When you have a patient that has a
Yes, so sometimes, so when you make the diagnosis of an MI, you have 3 things. History, physical exam, the story, labs, or the EKG. So it's the labs troponins. So you release troponins or CKMB, these cardiac markers. So those are the ones. So if I don't see ST elevations, but my troponin is high and the story fits, non-ST elevation MI. And that's the very simplified answer. There's a few more details we'll add to that. But that's a non-ST elevation. Very good. And the terminology change, guys. So right now, the correct terminology is if you have stable ischemia, it's called angina. That's not an acute coronary syndrome. And then we have something called acute coronary syndrome. Under that, we have unstable angina with a plaque rupture, and it's almost occluding the vessel, and infarction, which is a complete occlusion. Is that clear? And under that, we have ST elevation MI, non-ST elevation MI. That's the term we use now. Thank you.
Thanks, guys. All right, top of the hour. Thanks.
Thanks, Tom. Thank you.
Nice work, Steve. That was great.
Yeah, thanks for having me talk to him.
Appreciate it. Okay.
And we'll get through a lot of this stuff in our clinical case too. I want to make sure we bang it home.